So this patient is having a probable hypoglycemia. Remember, patient is using glimepiride, which is a sulfonylurea, which is going to predispose to high risk of hypoglycemia. So because sulfonylureas are long acting, they are more hypoprone compared to other drugs like meglitinides. So definitely with the symptoms given, I'm going to probably make a diagnosis of hypoglycemia clinically itself. So according to most guidelines, you can make hypoglycemia clinically, but you need that objective evidence. You need to do CBG or blood sugar and prove that it's less than 70 or less than 54. That's fine. But according to most guidelines, this is an urgent situation. So in the presence of autonomic features like shakiness, weakness, sweating for 1 hour, palpitations, tremors, so I'm going to make a diagnosis of hypoglycemia for sure. And because the patient is taking acarbose, so oral snacks may not work because acarbose is an alpha glucosidase inhibitor, and oral snacks may not work, and that's because acarbose might prevent the absorption of carbohydrates from the snack as well. So that is why my treatment here is going to be oral glucon D, simplest form of glucose that can be absorbed from the mucous membranes itself. So because the patient is conscious, it must be a level 1 or level 2 hypoglycemia, so I can go for oral glucon D. So give her snacks, I don't really recommend because the patient is already on acarbose. It may not work that much. And what about IV 25% dextrose? 25% or 50% dextrose will be tried whenever the patient is unconscious, not able to take care of himself. It's a level 3 hypoglycemia. For them, you can use IV 25% dextrose. IM glucagon can be tried in patients who are knocked out and unconscious in hypoglycemic coma, but you don't have IV line access for them. Maybe you can try 1 milligram IM glucagon according to ADA, but this is a simple case. So where I'm going to start with oral glucon D. That's it, nothing more than that.